This is Eric Strong from the Palo Alto VA and Stanford University. This is the abbreviated version of the 8th lecture in this course on understanding ABGs, and the topic is elevated anion gap metabolic acidoses. While lectures 3 through 7 focused on providing a collection of rules for determining a patient's acid-base status, lectures 8 through 12 will discuss the differential diagnosis for each of the 5 general pathophysiologic states of acid-base balance, and to provide some insight at how to establish a specific diagnosis in an individual patient. The full-length version of this particular lecture is the longest of the course and includes a fair amount of biochemistry that may be more detailed than some viewers are interested in. Therefore, I've made this version you're watching now, which cuts out some of the basic science and condenses commentary. The specific learning objectives of this lecture are to know the differential diagnosis of an elevated anion gap metabolic acidosis, and to be able to identify the specific etiology of an elevated gap acidosis in individual patients. For details on how the anion gap is measured and how to identify the presence of an elevated gap metabolic acidosis, please review Lecture 5. The differential diagnosis of an elevated gap acidosis is fairly long. In order to remember them, several mnemonics have entered into common usage. The most common of these is mud piles. I actually think mud piles is a horrible mnemonic and strongly advocate abandoning it in favor of 2 alternatives. First is gold mark. G is for glycols, O for oxoproline, L for L-lactate, D for D-lactate, M for methanol, A for aspirin, R for renal, and K for ketoacidosis. Another frequently used mnemonic is COLT, K for ketoacidosis, U for uremia, L for lactic acidosis, and T for toxins. I personally really like this because it's short, to the point, and gives a more appropriate level of emphasis to the 3 most common diagnoses. At this point, I'm going to talk about each diagnosis on the differential in some detail. As I said at the beginning, there will be some biochemistry, but not as much as in the full version. This is not for you to memorize, but rather to help you understand why certain diseases result in the specific types of elevated gap acidoses. I'll start with the most important etiology, lactic acidosis. So where does lactate come from? Here is a basic schematic of the formation of lactate. It starts with glucose, which undergoes the multi-step process of glycolysis to form pyruvate. Under normal circumstances, pyruvate is converted into acetyl-CoA, which can be entered into the citric acid cycle, where it converts chemical energy into something that can be used by the electron transport chain to generate ATP in a process known as oxidative phosphorylation. All of these steps here require the presence of oxygen and functioning mitochondria. In some circumstances, however, pyruvate is redirected elsewhere. For example, in anaerobic conditions, there is inadequate oxygen to allow the citric acid cycle and electron transport chain to function. There are also places where mitochondria aren't found, such as red blood cells, and circumstances where mitochondria are not functional. In these circumstances, pyruvate is reduced into lactate. That may be where lactate comes from on a biochemical scale, but where does it come from and go to on a more anatomic scale? Anatomically speaking, lactate commonly comes from 3 locations. First, as just mentioned, red blood cells which lack mitochondria and therefore require the formation of lactate. Second, whenever cells are starved from oxygen or have mitochondria that are for some reason not working properly, they produce lactate. Finally, in exercising skeletal muscle, production of NADH exceeds the oxidative capacity of the electron transport chain. The increased NADH to NAD ratio kinetically favors reduction of pyruvate to lactate. Now, once lactate is formed, what happens to it? Most will travel to the liver, where it will be converted back into pyruvate. Some pyruvate will enter the citric acid cycle, while some will enter the process of gluconeogenesis and be transformed back into glucose, at which point it will re-enter the systemic circulation. An alternate fate of lactate is filtration in the kidneys and elimination in the urine. This is usually only relevant once the blood lactate level exceeds a certain threshold, commonly believed to be about 5 millimoles per liter. There are also some rarely encountered additional sources of lactate. First, in some patients with bacterial overgrowth and high glucose delivery to the colon, intracolonic bacteria can produce excessive amounts of lactate, which can be absorbed through the gut wall. This condition, known as D-lactic acidosis, will be discussed in a few minutes. In addition, certain malignancies can produce lactate themselves for reasons which are not fully known. The malignancies most commonly implicated in this are lymphoma, leukemia, and multiple myeloma. There are a fair number of medications and toxins that have been associated with lactic acidosis. The known mechanisms are too diverse to review in any detail in this lecture, but they generally involve disruption of oxidative phosphorylation either by direct enzyme inhibition or by more general disruption of mitochondrial function. Metformin gets a question mark here because of significant disagreement in the medical community as to whether it actually causes lactic acidosis. I'll just say that the overwhelming majority of high-quality data suggests that there is not a cause and effect relationship between the two. D-lactic acidosis is a relatively unique form of lactic acidosis that occurs as a consequence of lactate having two enantiomers. The L enantiomer is the common form, which is produced in humans primarily via the reduction of pyruvate by lactate dehydrogenase. There also exists the mirror image of L-lactate, which is D-lactate. D-lactate does not normally occur in the body, but can be produced by colonic bacteria in patients who have undergone either jejunal ileal bypass or extensive resection of small bowel. In these patients, unusually high amounts of carbohydrates reach the colon, where the bacteria there metabolize it into D-lactate, which is then absorbed through the gut wall. Unfortunately, lactic dehydrogenase, normally responsible for catalyzing lactate's oxidation back into pyruvate within the liver, does not recognize D-lactate. Therefore, D-lactate accumulates as it is slowly eliminated via the kidneys or metabolized without the benefit of an enzyme catalyst. Many patients who have undergone significant resections of small bowel have asymptomatic mild D-lactic acidosis. When symptoms occur, they are largely nonspecific, but always include altered mental status with a consistent subjective observation that affected patients appear drunk. The labs of an affected patient will reveal an elevated anion gap acidosis after eating that resolves with fasting. Since standard assays for measuring lactate actually utilize lactic dehydrogenase, they are specific for L-lactate. Thus, these patients may appear to have normal lactate levels. There is a popular system of classifying lactic acidosis known as the Cohen-Woods classification scheme, which divides the etiologies into type A and type B. In type A, there is evidence of tissue hypoperfusion, such as that seen with shock, profound hypoxia, acute limb ischemia, and bowel infarction. In type B, there is no hypoperfusion. Type B has been subdivided into B1, which is lactic acidosis secondary to another medical disorder, most commonly hepatic or renal failure or malignancy. B2 is lactic acidosis secondary to medications or toxins. And B3 is that secondary to inborn errors of metabolism. Next, I'll talk about ketoacidosis. Ketoacids, also known as ketone bodies, are small compounds synthesized by the liver to be used as alternative fuel by cells during periods of relative glucose deficiency. Acidosis caused by the presence of ketoacids is well described in three situations: diabetes, where the condition is usually known as diabetic ketoacidosis, or DKA, starvation, and chronic alcoholism. To understand why these three situations produce ketoacids, as well as appreciate an important limitation of making this diagnosis, I'll need to briefly review the formation of ketoacids. Formation of ketoacids requires lipolysis of triacylglycerols in adipose tissue. This step is inhibited in the presence of insulin and stimulated by epinephrine, cortisol, growth hormone, and glucagon. The influence of regulatory hormones at this point is the reason why diabetics lacking insulin or in a state of physiologic stress can develop DKA. Also, during fasting states, insulin levels are low and glucagon high, which would also drive this process. The free fatty acids travel to the liver where the acetyl-CoA that is not utilized in the citric acid cycle is diverted into the formation of acetoacetate. Some acetoacetate undergoes spontaneous breakdown into acetone, which is responsible for the fruity smell sometimes detected on the breath of patients with DKA. Acetoacetate can also be enzymatically reduced to beta-hydroxybutyrate. Beta-hydroxybutyrate is the predominant ketone formed during states of ketoacidosis, particularly in alcoholic ketoacidosis, on account of an unusually high NADH to NAD ratio. Unfortunately, the standard nitroprusside assay, which is used by most labs to detect the presence of ketone bodies, only detects acetoacetate in acetone, which explains why there is a relatively high false negative rate with urine and serum tests for ketones. Beta-hydroxybutyrate can be measured directly, but this is often a test that needs to be submitted to an outside lab, and therefore the result does not come back within a clinically useful time frame. Renal failure. The elevated anion gap metabolic acidosis frequently seen in renal failure occurs for two reasons. First, there is failure to excrete hydrogen ions in the kidney. This is due to decreased excretion of ammonium ion and decreased excretion of titratable acids, predominantly phosphoric acid. The second reason is the accumulation of unmeasured anions. These include phosphate, sulfate, urate, and hypurate. Interestingly, there is only partial overlap between the cause of the acidosis and the cause of the anion gap, which helps to explain why patients with early renal failure may have only a non-gap acidosis and later on develop a mixed gap and non-gap acidosis. The anion gap rarely exceeds 20 milliequivalents per liter, even in advanced renal failure, so seeing a gap of this severity should always prompt an investigation for an alternative explanation. Next are the toxic alcohols, methanol, ethylene glycol, and propylene glycol. Starting with methanol, it has various industrial uses, is found in some windshield wiper fluid, antifreeze, and paint remover. Symptoms of methanol poisoning include vision loss, photophobia, abdominal pain, confusion, and lethargy. To briefly summarize the metabolism of methanol, it first undergoes oxidation to formaldehyde with assistance from alcohol dehydrogenase. The next step in the metabolism is further oxidation to formate or formic acid under regulation of the enzyme formaldehyde dehydrogenase. It is formic acid that is actually responsible for the increased anion gap acidosis, as well as all of the pathology that methanol toxicity causes. Finally, formic acid is broken down into carbon dioxide and water, a reaction which requires the presence of tetrahydrofolate. Ethylene glycol toxicity shares a number of features in common with methanol poisoning and utilizes very similar biochemical pathways. Ethylene glycol is a colorless, odorless, but sweet compound that is found in antifreeze and liquid coolants. Its sweetness is one of the reasons poisoning from it is disproportionately present in children and animals. The symptoms of ethylene glycol poisoning is usually broken down into three stages. First comes confusion within 12 hours of ingestion. Heart failure, myocarditis, and pulmonary edema develop at about 24 hours. And acute kidney injury occurs 24 to 72 hours after ingestion. The first step in ethylene glycol metabolism is oxidation by alcohol dehydrogenase. In this circumstance, the result is glycoaldehyde. Glycoaldehyde is further oxidized by aldehyde dehydrogenase to glycolate. Glycolate is one of the direct contributors to the elevated gap acidosis seen with ethylene glycol. However, it also impairs cellular respiration at the mitochondrial level and thus results in a concurrent lactic acidosis. Finally, after several additional steps, glycolate is metabolized into oxalate. Oxalate forms complexes with calcium, and these complexes are deposited into the kidney, heart, brain, and lungs, and is responsible for the pathologic features not attributable to the lactic acid. Ethylene glycol toxicity is diagnosed from levels directly measured in the blood, but strong supporting evidence includes the discovery of calcium oxalate crystals in the urine, which can be seen on light microscopy and which is likely to be quicker to obtain than the ethylene glycol level. Antifreeze, which is the most common source of ethylene glycol poisoning, usually also includes fluorescein, added to help trace the source of leaks in automobiles. Fluorescein, when ingested by humans, is eliminated via the kidneys. As a consequence, there is a long-held belief that looking for fluorescence when shining a UV light on urine can be helpful in making the diagnosis. This particular photograph is from a case in the New England Journal of Medicine. Urine from a patient with ethylene glycol poisoning is on the left, and a normal control on the right. Although this sounds like a cool and interesting bedside technique, there are a number of concerns that this diagnostic test has inadequate sensitivity and specificity to guide clinical decision making. The final toxic alcohol to talk about in detail is propylene glycol. This is used as a solvent for a number of IV medications, including lorazepam, phenobarbital, diazepam, and phenytoin. The typical presentation of propylene glycol toxicity is the onset of renal failure and an unexplained lactic acidosis in a patient who has been on a continuous infusion of IV lorazepam for at least several days. Quickly, propylene glycol is oxidized first to lactaldehyde and then again to lactate, thus the lactic acidosis. Eventually, the lactate is cleared by reduction back into pyruvate. An acceptable level of propylene glycol administration has not been formally defined, but commentary in the literature recommends a limit of 69 grams per day in patients with normal renal and hepatic function, which is the equivalent of 7 milligrams per hour of lorazepam. Other drugs are not infused at high enough rates to lead to propylene glycol toxicity by themselves, but will contribute to this problem if combined with IV lorazepam. Before we leave the topic of toxic alcohols, I should discuss the serum osmolar gap, which is frequently used to identify the presence of these compounds. Serum osmolality is predominantly determined by sodium, bicarbonate, chloride, glucose, and urea. It can be estimated by taking 2 times the serum sodium and adding the BUN in milligrams per deciliter divided by 2.8 and the glucose in milligrams per deciliter divided by 18. The osmolar gap is the difference between the measured osmolality and the calculated osmolality. There is normally a small gap, but accumulation in the serum of compounds of low molecular weight, such as toxic alcohols, will raise the measured serum osmolality above that calculated by the above equation. Small osmolar gaps are frequently seen in critically ill patients, but are usually less than 20 milliosmoles per liter. Thus, a gap greater than 20 strongly suggests the presence of an unmeasured osmol, particularly in alcohol. This calculation is helpful because many labs will be able to result a serum osmolality faster than a serum methanol or ethylene glycol level. General indications for determining the osmolar gap include suspected poisoning with an unknown toxin, an elevated anion gap in the presence of a normal lactate, ketones, and renal function, unexplained altered mental status, particularly in an alcoholic or child, and periodic monitoring for patients on high doses of IV lorazepam. There are a few compounds that can cause an elevated osmolar gap without necessarily causing an elevated anion gap acidosis. These include ethanol, isopropyl alcohol, diethyl ether, and mannitol. So I'm done with alcohol, and I promise we are almost through the etiologies. Just a few very quick ones left. Next is toluene. Toluene is an aromatic hydrocarbon commonly found in glues, adhesives, and paint thinner. While there are many organic solvents that are available for abuse, toluene has among the highest abuse potential and is particularly common among children and adolescents where they get exposure from sniffing glue. Its prominent acute effects are euphoria, loss of inhibition, and amnesia. In higher doses, it can result in slurred speech, ataxia, seizures, and a coma. In chronic abuse, patients can develop cerebellar dysfunction and dementia, as well as renal tubular acidosis, profound hypokalemia, and renal failure. Finally, the most recently discovered cause of an elevated anion gap metabolic acidosis is a naturally occurring metabolic intermediary called 5-oxoproline. 5-oxoproline, also known as pyroglutamic acid, is part of an interesting metabolic derangement seen almost exclusively in chronic acetaminophen use, related to the decreased levels of glutathione following administration of that medication. Additional risk factors for developing oxoprolinemia include advanced age, malnutrition, chronic illness, and alcoholism, all of which are also associated with low glutathione levels. The symptoms and signs of oxoprolinemia are non-specific and are the consequences of a severe metabolic acidosis. Diagnosis requires an organic acid screen of the urine and serum, which can take weeks to be resulted. I'm going to return now to the modern mnemonics that will help you remember the etiologies of an elevated GAP acidosis. They are Goldmark and CULT. Goldmark is for glycols, oxoproline, L-lactate, D-lactate, methanol, aspirin, renal, and ketoacidosis. And CULT is for ketoacidosis, uremia, lactic acidosis, and toxins. The last thing I will review is a general approach or algorithm to diagnosing the etiology of an elevated anion gap metabolic acidosis. First, always be sure the anion gap is adjusted upwards for hypoalbuminemia. Please see Lecture 5 for details on how to do that. Next, check the ABG to confirm that the patient doesn't just have an elevated anion gap and low bicarb, but actually has a metabolic acidosis as well. If there isn't one, you should consider causes of an elevated anion gap that don't cause an acidosis. These include severe hyperphosphatemia and the presence of an anionic paraprotein. Assessment of the pH will also help to assess the physiologic severity of the acidosis, as well as look for other concurrent acid-base derangements. Once an actual acidosis is confirmed to be present, check lactate and ketone levels, as these are the most common causes of an elevated anion gap acidosis. If lactate is elevated, assess for the presence of hypoperfusion. Systemic hypoperfusion means that the anion gap acidosis is a consequence of shock. If there is evidence of regional hypoperfusion, then the cause of lactate elevation is related to that. If there is an elevated lactate but no hyperperfusion anywhere, you should strongly consider a medication side effect, toxic ingestion, or lactate-producing tumor. If instead of an elevated lactate, ketones are present, and if the glucose is greater than 250, the patient likely has DKA, whereas if the patient is a heavy alcoholic, then alcoholic ketoacidosis is the probable diagnosis. If both lactate and ketones are normal, look at the renal function. A GFR less than 40 and anion gap less than 20 suggests that renal failure alone might be the explanation. However, if either the GFR is greater than 40 and or the anion gap is greater than 20, check the osmolar gap. If that is greater than 20, you may be dealing with a toxic alcohol. If the osmolar gap is less than 20, consider rare etiologies as well as a late presentation of methanol poisoning. The absolute last point to make is that the etiologies for the elevated gap acidosis are absolutely by no means mutually exclusive. It is in fact quite common for these to coexist in the same patient, which can hinder our ability to figure out what's going on. So that's it for the etiologies of an elevated gap metabolic acidosis. I hope you found this interesting and useful. Lecture 9 will cover the differential diagnosis for normal anion gap acidosis.